Dr. Timothy Gilbey. I am the Infectious Diseases Specialist for Murrumbidgee Local Health District.
So just in light of COVID, I guess what information can you provide us about how the disease actually works and how testing's going?
What was the first part of your question, sorry?
So how does the disease actually
How does the disease operate? Okay, so the COVID-19 virus, which is called SARS-CoV-2, as I'm sure you're aware, is a type of coronavirus which represents a novel strain and almost certainly represents a crossover between animals and humans. A respiratory virus. There are many other more common coronaviruses that we already have, but this new strain, given that it's a new event crossing over into humans, has the advantage of there being absolutely no previous population immunity, and that's why we have the issues we've got with the pandemic. Testing wise, we test for coronavirus in a variety of different ways, but primarily overall that's via a PCR type test, which is like a DNA test, essentially looking for virus DNA. The method to do that so far has been to take a sample of the secretions around the nose with a nasopharyngeal swab, is what it's called. Quite an uncomfortable procedure where you have to collect cell lining from the inside of your nose. Pretty uncomfortable. And we run that sample through a machine that extracts DNA or RNA, nucleic acid, and we compare those sequences to viral sequences, and that's how we essentially make the diagnosis. Like all tests, medical tests and other kinds of tests, there's nothing that's 100% perfect, and there are sometimes scenarios where you need to interpret the signal that you get before you decide if that is, in this case, a positive test or a negative test. And we've seen evidence of that recently, where there was the case that initially was felt to be possibly a positive test based on a very low signal, but on subsequent testing was shown to not actually be a genuine positive test. And I guess the analogy is, if you're listening to the radio, you're trying to listen to the cricket, you're out in the country somewhere, you're driving on the Hume, and the signal starts to go down, and you turn it up, and what you end up getting is lots and lots of static rather than lots and lots of real signal, and eventually you're in a situation where you have heaps of static. Maybe you can hear, one of the commentators' voices. You're not quite sure. That's the scenario with potential for false positive tests. Based on the nature of how the tests work, you can amplify junk rather than genuine signal.
So how important is testing at this stage?
Oh, critical. Absolutely critical. So we're lucky in the Murrumbidgee in which we've had, relatively speaking, a low case number. We haven't had any dramatic outbreaks, as we've seen in some other areas in Australia, but also certainly globally, and we'd like to keep it that way. We know that with the coronavirus, there's an increasing appreciation for its capacity to spread between people, not so much that don't have symptoms, but potentially those people who have very minor symptoms that you might not otherwise pay attention to. A bit of a scratchy throat, feeling a little bit off for a day or so, and then you're better. And we are appreciating more that that can happen in the day or two before people develop symptoms. So what's called a pre-symptomatic period. So with that in mind, we are supporting a very low threshold to testing for people who do have even minor symptoms, so that we can catch that community spread before it develops into an outbreak scenario.
Just on the false positive and the positive testing, from what I understand, there's 3 different areas you're testing for to get a positive result. Is that kind of how it works? You test positive and then you test other parts of the virus? Is that...
Yeah, so essentially what you're referring to is the different gene sequences, perhaps, and within any organism there's a wide variety of genes that you could target, and certainly that's the case for the coronavirus. Exactly what's being targeted depends on the lab, and so there are more than 3 that can be targeted, each some sequences have more problems than others. But you know, you will certainly, if you have an infection with COVID-19, what you would like to see is that multiple targets are positive, although you only need a single positive target, genuine positive, to make a diagnosis. And there are some laboratory measures that you'd look at in terms of whether or not it's a real positive or not. We spoke a bit earlier about the analogy with a radio signal. Well, I mean, if it doesn't take you many runs to get a positive, that tells you that there's quite a reasonable quantity of whatever it is you're amplifying there, and that's more likely to be a genuine positive. Whereas if it's a very faint signal, you know, it's a bit more questionable. So
can other diseases kind of create a faint signal for COVID? Like if you've got something else in your body, like a flu or something, like it can actually trigger a little bit of a...
yeah, so not the flu, but the capacity for one of those targets to cross-react essentially is what you're talking about. Cross-react with coronavirus. Generally, all the sequences that are used are felt to be very specific for COVID-19. It's more reflective of the technology itself, whereby if you amplify the material endless times, eventually you'll get a positive of detection of something, and that's what we're seeing, rather than a genuine cross-reactivity with another virus, for example.
Do you know that this is highly contagious? What makes this particular virus so contagious? And is that why we're so nervous about opening the floodgates to end social restrictions here in the Murrumbidgee without local cases first?
Yeah, it is quite contagious. It's not as contagious as some other things that we know. You know, measles, for example, tuberculosis are more contagious, but it is very contagious. And one of the things that makes it a particular concern is, you know, the fact that we don't have any pre-existing immunity in our community, and certainly that plays into the concern. As with many things, you know, there's a great deal of the unknown, and you know, how we approach the unknown always plays into to these kind of measures. And you know, we've seen globally the impact of unchecked or late recognition of outbreak scenarios, and how devastating that can be, such as the case that was in Italy, and is currently going on more in the United States. So that's the rationale for encouraging early testing and broad testing of people who do have symptoms, or even minor symptoms, so that we can catch that. Because, you know, firstly, we remain a vulnerable population. There is the capacity for pre-symptomatic spread or spread with minimal symptoms, and so the other thing that feeds into that, I guess, your question more generally, is the latency period. So if you have a high threshold to test people, then by the time you make one positive case detection, you've got a large number of lower symptomatic cases that have been spreading virus in that 2-week period, which is the incubation period. So that ends up with an exponentially large number of cases, and we try and ameliorate that with early testing.
We've got things like, we've seen what's happened in the aged care centre. Some kids returning to school this week. A little bit of restrictions eased from today. Are we confident that, from your expert opinion, that we're on top of this enough to control anything that might get out of hand with these relaxed?
Yeah. So I mean, as with all of these scenarios, there's not a right answer, I guess, and we relax restrictions, you know, with caution. I guess it's certainly reassuring that with the measures that were put into place, we did see quite a good response with the idea of flattening the curve, and you know, we didn't end up going on to have exponentially rising cases and overwhelming our health capacity, and we would expect that with the low threshold that we're adopting for testing, if and when further cases do occur, that we have the excellent public health response to deal with that, contain that, and have the healthcare capacity, particularly in the Murrumbidgee, to account for those cases, to accommodate those cases. Yeah.
Just further to Will's question, when the thing first started, staff were trained, there were staff that were now working in clerical positions who had nursing backgrounds, and they were asked if they could step back in. now that things have quietened down a bit, does that mean that the hospital itself and the staff within the hospital have quietened down with the thought
With
that,
general
this
stuff, do you
isn't
mean?
going to explode like we thought it may well at the start? Does it mean that the staff in and around the hospital have been moved back into other areas, or they've
That hasn't happened yet.
still training, etc.?
Yeah, there's certainly still some rotation through some of those high care, particularly critical care type environments. And I guess one of the most useful and important factors going forward in terms of the response is that it's been dynamic, and that we've got these capacity to change the way we do things. You know, medicine traditionally is very kind of rigid and doesn't like to change too much, and the hospital setting reflects that. But with the coronavirus pandemic, that's clearly not been able to be the case, and that's an advantage, I think. And so Len would have spoken previously about the virtual ward and how we're managing patients over a wide geographic area, and our capacity to do that with the technology that they've acquired is very good, and that will have some benefits going forward into the future. Similarly, in terms of how we're structuring the inpatient load, patients in the hospital, is a dynamic field, and that's the best way to manage that strategy, both in terms of staff and in terms of patients, remaining flexible, and I think that'll be the greatest asset going forward.